Well, good afternoon, everyone, and thank you so much for joining us today. My name is Tiffany Rubalcaba, and I'm the Associate Director of E-Learning with the California Primary Care Association. And on behalf of CPCA, as well as Partnership Health Plan of California and the National Center of Excellence for Eating Disorders, we'd like to welcome you to today's webinar. This is part 2 in our 4-part Eating Disorders webinar series. And today we will primarily be focusing on the role of primary care providers in treating eating disorders. So before we get started and I turn things over to our presenters today, I'm just going to go over a couple of housekeeping announcements to make our time more successful for everyone. You may have noticed that attendee phone lines are muted, and they will remain muted through today's presentation. If you have questions or comments at any time during our session, you can click that small radial button with the hand icon, and when you raise your hand and when we break for Q&A, I will then open up your phone line and let you know when you are fully connected so you can present your questions or comments to our panelists. Additionally, you can use that questions module there in the toolbox on the lower right side of your monitor. All questions chatted in during the presentation will be received by me, and I will present them on your behalf when we break for Q&A in the order they are received. You can use the same question box to communicate to me any additional needs that you might have, whether you're experiencing technical issues or if you have questions related to CPCA's other offerings. You can use that question box and I will chat directly back to you. So I do encourage you to kind of monitor that question box during our session today. We did email a copy of these slides to all registrants at about noon today. And but if you did not receive those, you can download them in the handout section now, and they'll be available for download anytime before the webinar is over. So we do wish to thank you for registering for today's webinar series. We do encourage you to visit our website at cpca.org to register for future trainings and events, which we have quite a bit coming up in the next month or so. So with that, I want to go ahead and introduce our panelists today. Joining us is Dr. Martha Perry. She's Medical Director with the UNC Children's Primary Care Clinic. And joining her is her colleague, Stephanie Zerwas, and she's an Associate Professor as well with the UNC Center of Excellence for Eating Disorders. So with that, ladies, I'm going to go ahead and turn presenter control over to you now. So you should be seeing that pop up on your screen to share your slides with us.
Okay. Can you see our screen?
Perfect. So I'm seeing your screen, but it looks like a blank slide. Like nothing has loaded.
Very strange.
Okay. We've got a screen back up. Perfect. There you go.
Fabulous.
Thank you.
Thank you so much for that introduction, Tiffany, and for having us here today. I'm Stephanie Zerwas.
And I'm Martha Perry.
We are sitting next to each other presenting this today. I want to have one other quick housekeeping item, which is that we are currently under tornado watch in North Carolina. So if you hear a sudden alarm sound, that is because it has switched to a tornado warning, and we hope to be able to continue the webinar today, but we might need to do so from the bathroom. So we'll just start with that brief introduction to our weather system. All right, so we have a few learning objectives today to review, and I know that this is building on a previous webinar. So one of the things we want to make sure that we do today is discuss best practices in primary care and for primary caregivers. We want to discuss about just the principles of weight assessment and doing a sensitive weight assessment for individuals with eating disorders. Dr. Perry will discuss the medical management of eating disorders further. And then we also want to articulate the best practices for collaboration across providers. Having an integrated, seamless team can be really important for eating disorders, especially to have the team speak with one voice. If we have time at the end of our visit today, we will also apply these principles to various case vignettes and talk about some of the pitfalls that might occur during the primary care visit for eating disorders.
I like that you called that a visit. So it will be nice to get everyone's input and questions and make it truly a visit where we have some back and forth exchange of information and questions.
We'll also talk about ways that we can match each patient to the appropriate level of care as well. So one of the places for us to start today is to really talk about how to measure weight during the primary care visit. Often I actually went to the doctor just this week for my own sinuses. You might hear me sounding really nasally. And it's amazing how commonplace it is and how much we take it for granted that the first point of contact between a nurse and a patient typically is, let's get you up on the scale. And we know that practice procedures can vary quite a bit across different practices. Oftentimes, as a clinical psychologist, I will have patients who have actively avoided seeing their doctor for a very long time because they're worried about getting weighed, they're worried about the weight being communicated to them, and even when sick, they'll opt to tough it out because they're concerned about discussing their fears around their weight, as well as having comments made about their weight. So communication and opportunities for collaboration with patients is really key. Here are some of the pitfalls that we hear about from our patients who have been weighed during their primary care visits. One thing that we might hear is that the nurse or the doctor complimented weight loss during their visit, which led them to think that their eating disorder behavior was actually having the desired effect, and that their eating disorder was something to be complimented for. So the types of comments that our patients will report hearing is, oh my gosh, what's your secret? Like, you're such a skinny mini, I wish I looked like you. Sometimes for patients who have anorexia nervosa, primary care doctors can compliment their weight gain and be really effusive in their compliments for, oh my gosh, you've done such a great job and I'm so proud of you that you are in the process of weight restoration and renourishing yourself. We know that our patients with eating disorders often find compliments for weight gain to be really aversive and will often get very upset that they are not acting in the ways that the eating disorder wants them to act. And so being neutral about weight is probably the best recommendation. Like I mentioned before, asking for recommendations about nutrition is a pitfall, as well as making comparisons or having statements like, oh my gosh, I wish I had your butt, or your arms are so toned, and like, I'm so impressed by you. And so that comments about body during this part of the visit can be often really triggering or difficult for our patients.
And I know as primary care providers, there's a lot of emphasis on making sure that we look at the BMI and that we look at weight. And while that is an important part in terms of looking at the trends, I think emphasizing what's happening around that BMI as opposed to the actual BMI. So asking about eating habits, asking about nutritional habits that include some of the important fruits and vegetables being taken in, as well as a balanced nutritional plan that includes your proteins and your starches. And so thinking about when you want to better understand or want to make a comment about weight, rather than making the comment about weight, delve into questions more about what their nutritional and activity practices are to better understand what kind of behaviors they're doing and whether those are healthy or unhealthy behaviors overall in terms of their well-being.
The other thing that you might hear is that patients will often ask for reassurance about their weight status. How am I doing? Am I doing okay? Do I look okay? And it can be a natural inclination to then offer up reassurance or a compliment. I would encourage you to take a step to the side, though, and say, wow, this this seems really important to you, or this seems like it's really difficult for you to step up on the scale, and open a dialogue that way instead. Some best practices for communicating with patients around the weight, and one is to post a sign asking if the patient would want a blind weight. People don't necessarily need to know their weight at each visit. And if you signal to the patient that having a blind weight is a possibility, you might be surprised at the number of people who would take you up on that. The other thing is it communicates to patients with eating disorders, even eating disorders that are unknown to you, that you are sensitive to these issues and are willing to talk to them about it. So how do you provide a blind weight? It might mean that you have to be really thoughtful about your scale choice, and whether you're having a scale like a digital scale that has shows a number off to the side, or that your staff feel really comfortable having somebody step on the scale and look away from the number.
There are different strategies. You can also, we have actually seen practices where they just tape something over the weight. Mm-hmm. They just flip it briefly to look at it and then flip it back, because sometimes what happens is the patient is facing away from the weight, they step off, and for many medical scales, the weight is still there, and they'll turn around and look at the weight. So having that piece of paper so we can glance at it so we know what it is, but then covering it back up can be helpful. And some of our staff will, in our clinic and in other clinics, will use a sticky note, for example, to write down the weight and carry it with them and not enter it in EHR in front of the patient. And that can be good, but the only caution that I would give you is we've had occasionally staff leave it in the room, and one patient left a note on the sticky saying, "My eating disorder thanks you for leaving this sticky note," because it had the patient's weight and information, and that was something that was fueling her eating disorder. So I think being careful about how you document in terms of patients not having access to it when they're not ready for it is important, and knowing what they have access in terms of their patient portals. You know, you can access almost all of your medical records on your phone, and so knowing what is going to be safe for them to access is important. At the end of the day, patients are going to find out their weight. If they really want to know, they'll figure out a way to find it. But if we can do as much as possible to support their recovery and avoidance of that until they're ready, we're going to see a smoother recovery overall.
And that being said, sometimes a manila envelope or a manila folder can be your friend, and just keeping that information separate from the patient in the visit. Another best practice is just to keep language neutral and judgment free. It's so common in our society to make comments on people's appearance based on their weight, status, and it's often just an easy trap to fall into. Oh my gosh, what have you done? You look amazing. You know, what's your diet plan? It's okay to make comments based on other ways to connect with people. For example, Martha has some really funky, awesome rain boots here today, and I think they look great. So talking about something like shoes, or asking somebody about what the message is on their shirt can be a great way to connect with patients, but it doesn't necessarily help anyone for people to be openly discussing their own diet or their own goal weights.
Mm-hmm. In terms of whether the weight is accurate becomes a really important question. And again, this is where we want to emphasize the trends as opposed to the absolute number. It certainly can be helpful when you're thinking about whether a patient needs hospitalization, and we'll talk more about that later. But patients' weights may vary for a lot of reasons. One might be that they're water loading, so that's when they take in excessive amount of water, hold their urine until they're weighed so that their weight will appear more. Urine-specific gravity can be very helpful in terms of identifying whether that's occurring, because you'll see a very dilute urine, or you may also see a very concentrated urine and a weight that's down, which might imply that the patient's dehydrated, because occasionally they water restrict. So part of the important procedure in terms of weight is not only having them weighed without seeing their weight, but having them empty their bladder before they are weighed, and collecting a urine where you then check the specific gravity. So you have a better understanding of how that weight really relates to their current overall nutritional status. There is a fair amount of fluid retention that can occur, especially in individuals who are restricting and develop hyperaldosteronism. So they'll hold on to salt, which in turn means that they hold on to fluid and can develop edema and swelling. So again, their weight may not accurately reflect their nutritional status. And that goes back to, again, the weight is one part of what we're evaluating. There's so many other elements in terms of their vital signs and their thoughts and behaviors that are going to be better clues to overall how they're doing.
One other thing to discuss is just physical manipulation of weight. It's important for us to say that this is not necessarily the individuals trying to be manipulative or sneaky, but it's really important to pull apart the person's eating disorder from themselves. So oftentimes the eating disorder, because the person relies on it for anxiolytic factors or just really wants to hold on to their eating disorder, they might manipulate their weight by putting things in their pockets. I've had patients put things like bottles of lotion in their underwear. Sometimes people will put things in the seams of their dresses or other sorts of clothes, using coins or sand or other ways to manipulate their weight. One thing to look for is if your patient always returns to a weight follow-up visit with the same dress on every time, that would be an indication that there might be something special about this dress. One way to get around this is to just have a standard practice of doing gown weights for patients with eating disorders. At times, it is not unheard of for patients also to put things in orifices in order to increase their weight. So it might mean if you, upon visual inspection of the patient, have suspicions that their weight couldn't possibly be that high, might mean jumping around a little bit in that gown before stepping up on the scale.
I've definitely had a number of patients who have inserted coin rolls in their vaginal canal, for example, to affect their weight. So really important just to consider that if you're seeing a big change in weight.
The other thing to consider is often parents and physicians wonder, where the heck did people get these ideas? And because of the internet, oftentimes ideas around physical manipulation of weight are widely shared in various locations. So it's not unusual for people to have really savvy ideas about what to do during the visit. All right, we want to take a little break here and just open things up to questions and have a chance to answer any questions that people might have about what we've discussed so far.
We'll switch gears after this and talk more in detail about medical evaluation and management, but wanted to give everyone a chance to comment or ask questions from anything that we've reviewed so far.
Great, thank you, ladies. Right now, I don't have any questions in queue, but now's a great time just to remind folks, if you joined a few minutes late and you have a question, you can either click that radial button with the hand icon and I can open up your phone line, or you can chat in your questions in that question module that's available there in your webinar toolbox on the right side of your monitor. But I have no questions at this time, so if you guys want to go ahead and proceed, that's fine.
Yeah, absolutely.
Oh, you know what? Hold on. I actually just got one, so let's go ahead and do this really quick. Should we ask patients if they prefer not to know their weight or just start blind weight in patients with suspected eating disorders?
I think it's a great conversation to have. I would prefer asking patients if they want to avoid their weight or have a blind weight rather than simply move to blind weights and maybe tip off the patient that you have suspicions about their eating disorder.
I think that you want to, rather than doing it only with patients with a suspected eating disorder, make it standard of practice where you're rooming the patient and you're asked, do you want to do your weight where you can see it, or do you want to do your weight blindly? And then in terms of whether to tell the patient their weight or not, I think that again, it's something that I typically try actually not to discuss, and just say, I want to hear more about your nutrition and your movement, and let's talk about what you're putting in your body, how you're fueling your body, and how you're moving your body. And try to talk about changes that we can make from that standpoint. And then certainly if there's an issue that comes up around the weight, that then we can delve into it there. But again, that sort of helps them see that my focus is not their weight, my focus is in how they're treating their bodies.
Any other questions?
All right.
Tiffany?
Nope, that's it. So let's move on. Thank you.
Thanks for that question. That was a great question.
Absolutely.
Now we'll move on into medical management, and this is where the physician or primary care provider is critical in terms of identification and then assessment of severity to better understand what level of care the patient might need, as well as what needs to be monitored ongoing, and then managing some of those medical complications or referring to specialists for further management. This is also the time where we want to refer and coordinate with the multidisciplinary team, and we'll talk more about what that team looks like. And I think it's good to practice and have the words that you're going to use to talk to families and patients about eating disorders, so that you can provide that education and support. As a primary care provider, what you tell them means a lot. I get a lot of patients referred to me as an adolescent specialist who will repeat things that their primary care provider said, some of which are maybe eating disorder promoting, and others that are very supportive and really help lay the groundwork and pave the way to a smoother recovery.
Okay.
I think it's nice to have just some basic recommendations that you make when you diagnose a patient with an eating disorder, and just to have some framework to start with. So one of the things that we want to do is review their activity. If there are any cardiovascular complications, we definitely want to consider activity restriction. Or if they're using the activity as a way of purging or a way of compensating for binging, we want to make sure that that the activity that they're doing, well, it's a healthy part of a lot of individuals' lives, that it truly is contributing to their health and not detrimental to them. And you'll need to gather information in terms of vital signs as well as an EKG to help determine what's safe for them. It's also a great idea to go ahead and start a multivitamin, calcium, vitamin D, and omega-3s. Those all can be beneficial. We know that there's evidence of osteopenia in many individuals with eating disorders, as well as just slowed bone mineralization. Oftentimes they're vitamin B12 deficient, or they may be slightly iron deficient. So again, adding a multivitamin with iron as well as those other supplements just gives them a little bit of a head start. And then I'll talk to them about just a very basic framework for eating patterns. Say, I want you to start eating 3 meals and 3 snacks. And they may say they can't do that. And I'll say, I want you to do the best you can. Get as close to that as you can. We're going to have you see a nutritionist. But in the meantime, let's start working on restoring your nutrition. And part of that's going to be eating more consistently throughout the day. Occasionally, they have trouble doing that, and then considering a supplemental nutrition drink like Carnation Instant Breakfast or Boost or Ensure can be a good thing to recommend, especially as a bridge until they're able to see the nutritionist, who may continue that supplement, but at least you're giving something to start preventing further progression or further malnutrition until they're able to see the nutritionist and get more specific guidance. Also important when we're talking about supplements is to think about the young men in particular, but really men and women who may be taking supplements as a way to build muscle mass, which is another kind of eating disorder that we see, where it's not necessarily about weight, but more about being toned and having no quote unquote fat on their body. So asking about supplements becomes important in terms of things that can be bought at nutrition stores and that may not be healthy in large amounts. So good to screen and ask about those, and really recommend limiting most of them. There aren't any that are truly very beneficial, and until we have a better understanding of what their nutritional status is and what they need from the nutritionist, I usually tell them, let's avoid those until you get guidance from the nutritionist, and then he or she can help you with figuring out whether those belong in your nutrition plan.
Oftentimes, with a recommendation for activity restriction, I will hear pushback from individuals and families just who are concerned that this is the primary way that they manage their anxiety. as a clinical psychologist, I often make the recommendation that we need to increase your toolkit on managing your anxiety and include other ways to ride out fears as well as just feeling uncertain about the future.
Now we'll delve into the various systems that are impacted. And the important thing to remember is that eating disorders are multi-system diseases, whether it's someone who has anorexia nervosa, bulimia nervosa, or binge eating disorder. All systems are affected in a variety of different ways. So as I talked about, an EKG becomes very important. Individuals may present with bradycardia or an arrhythmia. Prolonged QT is probably the most common arrhythmia, and that's usually due to electrolyte abnormalities. We certainly see orthostasis or hypotension as well. Patients may have symptoms of pre-syncope, syncope, or lightheadedness or dizziness, and they may not necessarily volunteer that, but when you ask about it, that's another hint that they may have orthostasis or hypotension. The gold standard for checking orthostatics would be to have patients lie for 5 minutes and then stand for 2 minutes. And if there is an increase in pulse by greater than 30 or a decrease in systolic blood pressure or diastolic blood pressure by greater than 10, then we're concerned about orthostatic hypotension or orthostasis associated with an increase in pulse. And oftentimes we'll see this because of a decrease in cardiac mass, and so we have stroke volume that's decreased, and so that cardiac muscle has to compensate by increasing rate to maintain cardiac output. So I will actually explain that to patients because that's an important part of understanding that when you're malnourished, it affects all of your organs, including your heart. Individuals who have anorexia nervosa and actually, as well as some individuals with bulimia, when they have an echo, about a third of them have mitral valve prolapse or pericardial effusion associated. And those usually self-resolve once nutrition is restored. So thankfully, there isn't a lot that we have to do to treat these symptoms other than nutrition repletion, ensuring they have adequate fluid intake, and certainly correcting any electrolyte abnormalities if they occur. The one irreversible complication would be ipecac cardiomyopathy. We don't see a lot of ipecac nowadays, so typically it's not something I have to worry about, but that is the one irreversible complication associated with an eating disorder that should be considered. One other symptom associated with cardiovascular changes would be that acrocyanosis, where individuals have cold hands and feet, oftentimes blue fingertips and blue toes. Again, something that maybe their family noticed or maybe you'll notice on physical exam, but not necessarily as something a patient's going to outwardly offer or volunteer. And again, that's an opportunity to explain to the patient that that's a sign that they're so malnourished that their blood is being shunted to all their major organs to survive, and the body has stopped thinking about the extremities that are less important for survival and function. There are lots of gastrointestinal findings to think about with all types of eating disorders. Certainly we see parotid enlargement with recurrent purging. In addition, dental erosions and oral ulcerations are common. I usually recommend referring automatically to a dentist if they haven't seen anyone recently, and making sure that that dentist is looking for enamel damage and thinks about doing things that are protective to prevent further damage. Of course, we want to help decrease the behaviors, but in the meantime, we want to protect their enamel to prevent significant long-term damage. Individuals may have GERD or esophagitis, and that can be from recurrent vomiting, that can be from associated with malnutrition and undereating, that can be associated with binge eating. So all of the eating disorders can cause these symptoms, and we want to think about protecting the gut with an H2 blocker, because long-term esophagitis or GERD certainly could put them at risk for Barrett's esophagus, and sometimes with significant forceful vomiting, we'll see Mallory-Weiss tears as well. A very rare but important complication is superior mesenteric or SMA, superior mesenteric artery syndrome, and that's where the duodenum is compressed between the aorta and the superior mesenteric artery. That occurs because of a loss of the abdominal fat pad, and it causes significant epigastric pain. And the reason I mention that now is that sometimes it's mistaken for esophagitis or gastritis, but is actually SMA syndrome and requires significant treatment. That's one situation where I would probably refer to a gastroenterologist for further assistance in management. Delayed gastric emptying is quite common, again, with all types of eating disorders. Many patients will complain about constipation, bloating, diarrhea, IBS-like symptoms, whether it's related to binge eating or whether it's related to purging or whether it's related to restricting. They get quite uncomfortable and they do experience significant bloating. They look at their belly looks bigger. They feel like they're getting quote unquote fatter. And so it's really important to have conversations with them about that. Yes, your belly is bigger right now. Validate that experience. It's temporary and it's part of your recovery. Gastric dilatation can occur with chronic binge eating, and there actually are even cases of gastric rupture. And then pancreatitis, certainly from excessive fat intake, carbohydrate intake can occur. Elevated transaminases are also quite common in the setting of starvation in particular. Those are typically transient. They don't need any intervention other than nutritional repletion. But all of these are important areas where we can point out to patients ways that their body is being affected by their eating disorder. The constipation and bloating, typically, again, we like to treat with nutritional repletion. However, sometimes it can really get in the way of their recovery, and so we will use sometimes a stool softener. We just want to avoid laxatives. So something like Miralax or Colace is reasonable to try, and sometimes we'll use a glycerin suppository. We try to avoid anything that's osmotic or stimulating, and that can make quite a difference to help them move along and be able to take in more to increase their intake and improve their nutritional status. Metabolic findings include lots of different electrolyte abnormalities. So water loading, we'll see hyponatremia. Vomiting, we'll see hypochloremic alkalosis. With laxatives, we'll see hypochloremic acidosis. Diuretics can cause a variety of different electrolyte abnormalities. And then we also worry about refeeding syndrome, which is where an individual in a starved state is refed and they have a massive influx of insulin and all of their extracellular, or a lot of their extracellular potassium, phosphorus, and magnesium are shifted intracellularly, resulting in cardiac arrhythmias and even seizures. That's something that typically we monitor for in the hospital. Individuals that are sick enough to be at risk for refeeding syndrome often are hospitalized, and we'll talk more about hospitalization level. With metabolic syndrome, we're really talking about individuals that have bulimia, who are binging and purging, or individuals who have binge eating disorder. So we want to make sure that we're monitoring triglycerides, monitoring for insulin resistance and hypertension, and treating the metabolic syndrome as we would any patient. Again, nutritional repletion and stabilization of eating habits will help, but in the meantime, we want to prevent any of the other associated comorbidities. In terms of electrolyte abnormalities, we typically try to replace orally as much as possible. We try to avoid IV fluid and replenish it as much as we can with oral solutions. Endocrine findings, as you can imagine, are quite common because of the overall stress related to whatever eating disorder it is, resulting in hypothalamic suppression, and hence all of your pituitary hormones are typically lower than we would want them to be. That results in amenorrhea in many young women, as well as menstrual irregularities, oftentimes as oligomenorrhea. And those individuals are obviously at risk for reduced bone mineral density because of a lower overall estrogen state, as well as those that have reduced fat mass. That also puts them at risk for reduced bone mineral density. We'll talk a little bit more about some of the treatment options for that. Mostly, surprise, surprise, nutritional repletion is what will help fix this issue. However, we want to make sure that we're monitoring bone density in individuals who've been amenorrheic for longer than 6 months, and that any Z-score less than -2 is evaluated by an endocrinologist to consider supplemental estrogen or to consider bisphosphonates and other potential interventions. Sick euthyroid syndrome is something where we see lower T3 and sometimes T4 without an increase in TSH in response to that. And that's something that we see in the intensive care unit and in other settings where individuals are really sick. And this is a very helpful finding to demonstrate for parents and patients how sick they are. They have findings similar to individuals who are in the intensive care unit. And I mentioned already, so I won't spend too much time on it, but hyperaldosteronism also occurs and results due to vascular depletion. And so individuals hold on to their salt and then retain water, and that will result in some edema. Dermatologic findings are quite common, and again, something that maybe patients and families haven't been that in tune to, but pointing it out can be very helpful in terms of recognizing, again, how sick they are. So that's rough, dry skin, orange discoloration from excessive vitamin A consumption, easy bruising, bruising or abrasions along the spine, calluses on the knuckles from recurrent purging, and hair loss, as well as lanugo related to malnutrition. The lanugo is most commonly on the upper arms and sometimes on the face, and this is the body's way of preserving temperature, given that the individual who's in a malnourished state is likely hypothermic to preserve energy and function. Finally, you'll see some hematologic findings with bone marrow suppression. We might see leukopenia, which thankfully does not cause immunosuppression, but is another important finding to discuss with patients and families. We want to replace any iron or B12 that's deficient. And in the interest of time, I won't talk too much, but certainly we can see renal findings related to poor protein intake, resulting in renal insufficiency or an inability to concentrate the urine, or low BUN. And one of the reasons I mention this is sometimes patients are hospitalized, they're given more fluids, they're given more food intake, and they're having excessive amounts of urine output. And you want to make sure they're not using diuretics surreptitiously, but oftentimes it's because they have reduced renal concentrating ability. And over time, as their nutrition improves, that will improve, but sometimes initially they actually lose weight because they're diuresing so much related to that decreased concentrating ability. There is evidence that individuals with malnutrition have reduced brain volume and some neurocognitive impairment. This often results in disrupted sleep, a flat affect, or a more anxious activated state. So you may see a patient that doesn't want to sit during the visit or might pace in the room during the visit, or is maybe in constant movement. And those are important observations to make in terms of thinking about what kind of activity restriction they need or what kind of additional supplemental care they might need. The good news is the reduced brain volume will restore when their nutrition is replenished. There's a few common myths that come up that we just wanted to touch on. One is bradycardia and amenorrhea being expected in female athletes. I hear that a lot from patients and families. Sometimes it comes from their providers and sometimes it comes from their coaches. Bradycardia, a heart rate of less than 45, typically is not an expected finding in an athlete, either female or male, actually, and definitely requires further evaluation. There are occasions where it's related to a family history of bradycardia, but typically when you get below 45 and certainly below 40, it's not a familial issue and it's more a nutritional issue. Amenorrhea in the female athlete is never normal. So I think we used to be under the assumption that the stress and the activity level caused hypothalamic suppression, and that resulted in amenorrhea. We now understand that that the reason an individual is amenorrheic is either because they have insufficient fuel or because the fuel they're getting isn't balanced in a way that allows hormone production. So they may need more fat intake or they may need more protein intake, but this is a really important thing to think about with them. Many times they're put on birth control pills to get their periods back, and that's actually not helping because then we don't have a good gauge of restoring their nutritional status. And in addition, it sometimes gives a false sense that there's improved bone mineral density, and birth control pills have been well studied and do not improve bone density. The other thing that we sometimes see is that an individual's maybe was in the 85th to 95th percentile BMI. They've lost weight and their BMI is now the 50th percentile, and they'll hear from a provider or parent or coach, if you just stay in that range, you're fine. Well, it really depends on how they got there. If they've lived in the 85th percentile their whole life, that may be where they belong. If they lost weight rapidly and they did it at great expense, they're malnourished, even if they're at the 50th percentile. An individual who was at the 110th percentile, who goes to the 95th percentile, but does it in an extreme way, may be malnourished. So thinking about what it means to be malnourished when you have rapid weight loss becomes really important. And finally, I have a lot of folks get referred to me around the age of 16 because menarche was delayed. Typically, menarche needs to happen about 2 years after thelarche. So breast buds happen, and about 2 years later, you have menarche. So if an individual starts breast buds at 11, I would consider menarche delayed if they haven't had menses by, say, 14. So I wouldn't wait till 16 to start that evaluation, because then there's an extended period of time where we haven't investigated possible etiology, is sometimes related to a low estrogen state due to undernutrition. In terms of pharmacotherapy, unfortunately, there's not a lot of great evidence and not many studies that show benefit from pharmacotherapy. There is a couple of open trials related to olanzapine, an antipsychotic that at low doses, 2.5 milligrams to 5 milligrams at night at bedtime, may help reduce anxiety, which may help with recovery in terms of anorexia nervosa. There aren't any medications that are associated with weight gain when treating anorexia nervosa. We do see, though, in several randomized controlled trials that fluoxetine can help decrease binge purging. And it's important to know that those randomized controlled trials were with about 60 milligrams of fluoxetine. So oftentimes, especially in the pediatric world, we have a tendency to start with 10, 20 milligrams. We need to go a little faster and a little higher if we're treating bulimia nervosa. For binge eating disorder, the FDA has approved lisdexamfetamine, which is Vyvanse, which has shown some evidence. Again, the evidence is limited. It really has to be coupled with therapy and nutrition and working on stabilization of eating patterns. Many individuals experience anxiety and experience it in an unpredictable way, especially when trying to recover and trying to stick to a meal plan or stick to an overall treatment plan. Hydroxyzine can be very helpful in that situation. 25 milligrams every 6 hours as needed can help them get through the day or help them get through a meal in a way that makes it a little less stressful for everyone.
One thing to note is oftentimes our patients with anorexia nervosa who are prescribed olanzapine will research olanzapine on Dr. Google and look in or really study the insert and see that olanzapine is associated with weight gain. Paradoxically, we don't see that rapid weight gain in our patients with anorexia nervosa. Often it has none to minimal effect on weight whatsoever. So informing patients about that is critically important, because they will often refuse to start the medication because you're just trying to make me gain weight.
Mm-hmm. Medications to avoid include bupropion, really for two reasons. One is it can decrease appetite. In fact, it is sometimes used for binge eating disorder, but in patients with bulimia nervosa or in patients with anorexia, there is risk of seizure already associated with electrolyte abnormalities, and so we want to not add additional risk with bupropion, which can lower the seizure threshold. In addition, thinking about the risk of prolonged QT, if we're thinking about adding medications that also prolong QT, we want to avoid tricyclic antidepressants and potentially some neuroleptics if at all possible, given there's already a risk of increased QT. And we talked a little bit already about avoiding laxatives. Certainly, chronic use of laxatives can result in pretty significant long-term impacts on bowel function and even result in rectal prolapse. Trying to avoid those as much as possible and discontinuing those if they're part of purging behavior becomes really important. In terms of what we know is the best medicine is food. And I talk to patients a lot about food as medicine. And I talk a lot about when we give an antibiotic, we give it at a certain dose, and we're giving food, we're giving it at a certain dose. And we know that's what their body needs right now, even if their eating disorder is telling them differently. And we know this based on science and years of medical research. And we know that that information is more reliable than the information the eating disorder is providing. So having that conversation with the patient becomes important. When we think about setting expected weight in terms of where they need to get back to or restoring back. We really want to look at where they were on the growth curve, particularly in terms of their body mass index. Were they in the 75th percentile for most of their childhood and teen years? Then we want to aim for a weight that's going to get them back to the 75th percentile. That being said, what we really want to focus on is normalizing the eating patterns, tolerating energy-dense food, and increasing variety of food. The other thing is, initially they may be on a pretty structured, fairly rigid plan, but over time we want them to develop some flexibility around food, and ultimately perhaps be able to enjoy food again, and see it as something that is not so much of a challenge, but more of something that they can enjoy socially, and be able to enjoy their friends without having to be anxious about what kind of food is around them.
The example I often use is the sort of last-minute pizza party and being able to enjoy that and enjoy the time spent with friends, because often our social activities are centered around food. One thing to talk about is the Minnesota Starvation study. This was a study done in the 1940s with healthy young men who were conscientious objectors to World War II. And during this study, they took healthy young men who are eating on average 3,000 calories a day and reduced them to 1,500 calories a day. They lost weight rapidly, but they also had really intrusive thoughts about food, eating, and had pretty significant sleep disturbance. They also had increased anxiety and emotional disturbance. They studied recipes, they discussed food, they had weird food rituals when eating together. So this study was actually transformational in our understanding of malnutrition, and also a lot of the malnourished behaviors that we see look like eating disorders. And so oftentimes we see a reversal of these things when our individuals are no longer in the malnourished state.
We kind of touched on this already, but we want to think about setting an expected weight that would get them to their pre-morbid weight status, so wherever they tracked from a BMI status, and really reversing the medical and psychological instability that we're seeing. And when we get to that right set point, some of it is the weight, but also what I always tell patients is that we'll know you're better when you're not having disturbed sleep, when your vital signs are improved, when you're not lightheaded every time you stand up, when you're not cold all the time, when your GI tract is working. So when we know your body is functioning, then we know that you're getting close to or you're in recovery. And that's a really important message to give them, that it's not just about getting to a weight, it's about getting to a point where those symptoms are reduced or gone.
One thing to consider about reintroducing exercise into somebody's life again is to be mindful of their heart rate, and also to make sure that you're really assessing their frequency of exercise as well as their intensity of exercise. Our patients will also often describe that exercise feels compulsive, and sometimes they'll come up with games with themselves that they have to do X number of minutes per day, or they have certain magical thinking that occurs about how much exercise they're doing. So some things to consider is, have their weight restoration goals been met first, as well as being in close contact or communicating with other people in their life who might be providing very different recommendations for exercise. So if you are providing one message and they're getting a very different message from their coach or their physical trainer, it might be undoing or undermining the message that you're delivering. So finding ways to reach out to those other people in their life can be extremely important. Any questions?
That was a lot to cover in terms of the medical complications, but hopefully that gives you a brief overview as well as some of the strategies that we use to manage those things.
Yeah, great, thank you. So I do have one question here. They're seeking for any advice for addressing lab results that indicate compensatory behaviors such as potassium imbalances, bradycardia, etc., when the client is adamantly denying those behaviors. Do you have any advice for addressing patients?
Sure. Typically, when I'm in that situation, I don't force them to admit to something that they're not ready to admit to, but I do say that these are medical issues that we have to address. So figuring out how to address them together is what we're going to need to do. And if we can't figure it out together here, that might mean that we need to do it in the hospital, because these are dangerous lab values that can affect your cardiac function, or that can affect that could even result in sudden cardiac death. So I'm pretty straightforward in terms of the dangers and risks of what we're seeing, as well as not necessarily pushy that they admit to something, but more that if that's not going on, then we need to understand why we're seeing this in your labs. And that means we're going to need to work together to investigate it and be detectives to try to figure out what's happening.
Great. And can you clarify, what is QT?
Oh, so an EKG has various intervals on it that reflect your cardiac rhythms, and QT is actually just the letters that reflect that interval. And that interval, if it's longer, can increase the risk of other dangerous heart rhythms that can be potentially fatal. So QT doesn't actually stand for anything. It's actually the Q and the T that are specific points on the EKG. And if that interval, the point between Q and T, increases on the EKG, we're concerned that there's a problem.
And then bed and bowl obstruction. Have you seen this?
Bowel obstruction.
Oh, bowel obstruction. Sorry.
Oh, sorry. They said, okay, yeah.
I have not seen bowel obstruction in teenagers. I mean, I think the closest thing to that would be the SMA syndrome that we talked about, where that can cause vomiting due to compression of the duodenum and a lot of pain as well. I imagine that we might see bowel obstruction in adults who've had long-standing purging or long-standing laxative abuse and have really significant gastroparesis. So maybe not necessarily bowel obstruction, but just such severe gastroparesis that they're unable to pass all the way through their intestinal system.
I have had one patient who did have a twisted bowel, and it was unclear as to the etiology of that, but the suspicion was that she did not have enough abdominal fat to maintain bowel function.
Okay, and then last question, and then we'll get back to the slides. What would your message be to the patient with active eating disorder but has normal vitals and labs, which the patient then uses to argue not needing recovery?
This is a common issue. And actually, we're going to address it a little bit on these next slides. So I think I want to just put a pin in that really quick, because we're going to talk about the need to have other people involved in the eating disorder care. And oftentimes collaborating with a team, it means not just collaborating with all of the caregivers in the medical system, but it can also mean collaborating with caregivers outside of the medical system. So we'll talk about that a little bit more too. So when we think about collaborating with a care team, oftentimes this can include dietitians, mental health, primary care, as well as psychiatry and adolescent medicine. I'm eternally grateful as a psychologist that I have really strong collaborators, such as Dr. Perry, that I can call on, and that we can all talk and have a really straightforward, similar message, because oftentimes our patients can get very upset if they are trying to integrate very disparate messages across multiple providers. So back to the question that we talked about before, it's really critically important to involve the family in the treatment of eating disorders as much as possible. And that's definitely true for children, adolescents, young adults, but it's also true for adults as well. So typically, we know that eating disorders run in families, not due to parenting behaviors, but due to genetic factors that predispose some individuals to develop eating disorders. And it's really important to use the visit to reduce guilt or blame on the parents. Oftentimes, the first thing that a parent hears if their child is struggling with an eating disorder is, what did you do? Did you do something wrong in parenting them? What sort of messages have you given them about food and diet? Parents are our most important sources of support. So in children and teens, involving the family might mean charging the parents with really normalizing that eating pattern. And often parents can act as almost skilled professionals in providing meal support throughout the day, as well as learning how to provide emotion regulation tools for their patient or their child who's struggling with the eating disorder.
I often say that, you know, we're parents can be coached. We're kind of coaching them to do this. And the only other thing that I would say is that sometimes we observe what we would perceive as kind of pathological interactions or relationships. Oftentimes those are in response to the eating disorder as opposed to the cause of the eating disorder. And they don't necessarily need to be sorted out as much as to engage the families in terms of helping them to refeed their child and recover from the eating disorder.
In adults, this can look like other roommates, close friends, as well as family members and romantic partners as well. So as much as you can, don't just look at the patient as themselves, ask them to bring other people to their visit. An important thing to notice here is that oftentimes anorexia nervosa in particular robs the sufferer from understanding the seriousness of the disorder. So the denial of the seriousness of the disorder is actually one of the DSM criteria, and it really isn't that they're actively denying it so much as their eating disorder prevents them from seeing how serious this truly is. Oftentimes I hear from people, oh, the individual has to want to recover from their eating disorder before they can recover. That is not true. Oftentimes people can recover from their eating disorder with the support of a community even before they really want to recover.
So when you're talking about that patient who verbalizes they have normal labs and normal vitals, you still want to talk about, okay, well, let's not focus on that as much as let's focus on what your body's getting, the fuel that your body's getting. And we know, again, based on years of science, what your body needs. And I don't think your body's a miracle of science. So let's figure out what your body needs. Let's give it a try, and maybe we'll see some changes. Maybe there's things that you are experiencing that you're not even recognizing right now. And sometimes that can be, again, when we challenge them with a little bit of science, sometimes that can be helpful.
So do you want to discuss?
Yeah, so in terms of the role of the PCP, as I talked about before, it's that initial screening, that assessment for the medical complications, and then you're wanting to determine the level of care. And we'll talk a little bit about medical admission criteria, and then Stephanie's going to talk a little bit about different levels of care. And then ongoing visits are typically anywhere from once a week to once a month, depending on other team members that are involved and how often they're seeing them. I typically like the patient to have at least one person or point of contact every week if they're not going to a higher level of care. And the consensus cannot be overemphasized. Sometimes patients hear different things or interpret things differently, and we're saying the same things. So if they know we're talking and we're aligned and we're using the same language, that can be very helpful in terms of there not being misunderstandings or miscommunications with the patients.
Oftentimes, eating disorder treatment involves various levels of care, and we can talk a little bit about, we're running out of time, but at the same time we can talk a little bit about when those might be necessary. A great website to look at is findedhelp.com. It lists individuals who specialize in eating disorders both by insurance carrier as well as location, and it gives you a sense of who might be in your area who you collaborate with. I would say reach out to those people now, know who your collaboration team is even before you have a patient, so that you're prepared once a patient walks through the door. A therapist works really hard to help the patient face their fears about weight, face their fears of gaining weight. We do this through cognitive behavioral therapy, and as well as we talked about the importance of family and family-based therapy. the dietitian is really truly managing nutrition guidelines, explaining dietary exchanges. Dietitians can often break down the biochemistry of what is necessary and challenge a lot of the food myths that the people who are coming to the visit are walking in. We often get very conflicting dietary rules and information about what appropriate nutrition looks like.
I have a lot of patients who get information from YouTube videos. There's a big emphasis on something called nutritional ketosis, and there's significant damage going on when that's occurring. And I think having a conversation with nutritionists about what they need and why that's dangerous for the body is very helpful.
Levels of care, and we'll review this briefly, and then I think we'll have to stop. It includes inpatient, hospital-based, medically acute care. The step down there from inpatient is residential level of care. It is also all day. It's a less medically acute setting, often more of a homey setting. Partial hospitalization typically includes day treatment Monday through Friday. That's usually around 40 to 45 hours a week. Intensive outpatient programs include 2 to 3 times a week, 3 to 5 hours a day. And then outpatient can be 1 time a week, but it can also be 4 separate medical appointments. And at some point, parents and patients need to look at whether they want to do that or if they want to have a more robust team in an intensive outpatient setting.
There are specific society guidelines that some of which is based on limited evidence, and I think these are going to change and evolve over the coming years, but it really helps to review those to know what are considered medical criteria for admission. Part of that's ensuring that it's paid for and covered by insurance, and then it's determining whether they would be in a medical unit with psychiatric consultation or whether they would be in an eating disorder unit or a psychiatric unit with medical consultation, and that's very institution specific. Some eating disorder units are comfortable taking patients who have a heart rate below 40, some are not. So knowing what your institution where you would refer to will take is very helpful. I have included the Society for Adolescent Health and Medicine criteria for admission here, or at least having 1 or more of the following justify admission, and the American Academy of Pediatrics has similar criteria. Many of us are using slightly less stringent criteria, so bradycardia maybe not less than 50 during the day, maybe more like less than 40 to 45, for example. And oftentimes orthostatic changes or hypotension we don't look at that alone, but we look at it in constellation with what else is going on, if they're symptomatic, if they've had syncope. Those are patients that probably need some medical stabilization and monitoring before they're ready for another setting or to resume outpatient management.
All right, ladies. Well, I really hate to cut this off, especially on such an important topic such as this one, but time got away from us. So yes. I just want to take a couple of minutes really quickly to let folks know today's session has been recorded. We will send you a link that will have the recording in it by close of business this afternoon. And then you'll receive another follow-up email, which has the link for the 3rd webinar in our series a little bit after that. I know we ran out of time, but if you still have questions, please, I'm leaving the session open. You can continue chatting those in, and we will follow up with you to respond to all of those questions. And then just really quickly, in the emails that I sent to all of our registrants, there is a link to a very quick survey. It's really important to us that we can capture that information. So I know about half of you have responded to that survey, but the other half have not. So if you can take just 5 minutes and complete that survey, that would be very helpful to us. And with that, I'm going to go ahead and close out our session today. I want to thank our presenters for sharing this valuable information to our members. Really appreciate your time and the thoughtfulness in putting this together. I'm sorry we ran out of time. But I also want to thank our audience for their participation today. So thank you again, everyone, and have a wonderful afternoon.